My name is Dr. Alexander Apkin. I'm a medical director of the weight loss surgery program at Clare's Dover Hospital and a president of Advanced Laparoscopic Surgeons. Today begins the first step in your journey to better health. Our goal is to support you through every step of the process. Over the next 45 minutes, we will provide an overview of our program and services. We'll talk what to expect before, during, and after surgery, lifestyle, diet, and exercise changes, and how to maintain a healthy weight after the surgery is over. By the end of this video, we want you to feel empowered to make a decision that is right for you. Thank you for trusting us with your care. What are you going to learn today? We're going to talk about what obesity is. We're going to talk about what your daily challenges are now. We're going to talk about what obesity is costing you. Then we're going to talk about what surgical options are. And then we're going to help you to make the next steps if you're ready to healthier, better you. Next video is going to talk about obesity epidemic in this country, and we'll explain in detail why surgery remains the only reliable, durable options for weight loss despite abundance of diet and exercise programs.
Recent research is revealing the true nature of obesity, shedding light on one of today's most common questions. Why can't I keep the weight off? The traditional view that obesity simply results from a failure to maintain a healthy lifestyle overlooks how the body regulates energy. Recent studies show that weight regulation is a complex process governed by hormonal and neuronal signals between the brain and a system of organs and tissues. New research also reveals that as body fat levels increase, the body adapts and sets this elevated weight as a set point or a new normal. Since this new fat level is recognized as ideal, the body will attempt to maintain it. With this elevated set point, the body defensively responds to even modest diet restrictions by increasing hunger and cravings, decreasing satiety, and slowing metabolism, all to prevent starvation. As part of a basic biologic instinct, well preserved throughout human evolution, even an obese body is programmed to protect fat levels. Because this weight-regulating mechanism does not recognize obesity and subsequently does not allow the return to a healthy weight, obesity presents in patients as a chronic disease. Similar to other metabolic functions, such as blood glucose, LDL cholesterol, and blood pressure, body fat set points are affected by genetic predisposition, environmental exposure, and developmental history. Though all of these factors contribute, the recent epidemic rise of obesity can be primarily attributed to the modern environment. Negative changes include alterations in the chemical and nutrient content of our food, a lack of exercise, high levels of stress, inadequate and disrupted sleep, and the widespread use of weight gain-promoting medications. The result is that many individuals have become obese and, despite efforts to lose weight, remain so or even gain weight due to the compounding effects of metabolic dysfunction. For effective weight loss, calorie intake must decrease and calorie output must increase. However, the obese body treats a calorie reduction as a starvation threat and defends by conserving energy and restoring energy-rich fat. Throughout most of human history, calories were scarce and hard to get, so we have numerous natural defenses against starvation. We have no defenses against overeating because we never needed them. A landmark study of over 4,000 patients found that on average, fighting obesity with diet and exercise alone only achieved a 20-year sustained loss of 4 pounds. The New England Journal of Medicine reported that though dieters may initially lose weight, their bodies then encourage fat regain by triggering a cascade of changes in hormonal and neuronal signaling, which did not return to pre-diet levels even 12 months later. This unrelenting self-preservation mechanism may explain why most weight loss attempts fail in both the short and long term. Successful weight loss is important because obesity has been linked to increased risk for diabetes, an ever-increasing public health threat, as well as cardiovascular disease, the world's leading cause of death. Other diseases related to metabolic dysfunction have also been linked to obesity. The key to reducing these health risks and successfully treating obesity long-term appears to be treatments that change the physiological body fat set point. For many patients, this requires therapies that can deliver long-term weight loss of more than 10%. New research indicates that bariatric surgery, increasingly referred to as metabolic surgery, has lowered set points and had profound metabolic impacts beyond that of weight loss. The surgery changes hormonal and neuronal signals, decreasing appetite, increasing satiety and metabolism, and encouraging healthier food preferences. Positive weight-independent changes, such as glucose homeostasis, lipid biology, and more, have also been observed. The New England Journal of Medicine reported that more than 3 times as many diabetics achieved glycemic control of 6% or less through bariatric surgery versus those who only underwent intensive medical therapy. This new data on the complexity of weight regulation, the concept of set points, and weight loss study results has shown that diet and exercise may not be enough to achieve the most advantageous long-term benefits for obese patients. In contrast, metabolic and bariatric surgery patients experience, on average, over 45% excess weight loss and lower body fat set points. This allows them to successfully keep the weight off, reducing their risks for a host of obesity-related diseases and improving the quality of their lives.
We've been doing laparoscopic bariatric surgery since 1999. We've performed over 7,500 procedures. We were the first to implant a lab band in New Jersey in 2001. Our practice is designated as a center of excellence in bariatric surgery, and I've been named top doctor by New Jersey Monthly Magazine 10 years in a row. But you may ask yourself a question: why does it matter? The reason why it should matter to you, because nowadays more than ever, bariatric surgery is very popular, and many practices and hospitals claim that they have the best outcomes. But it's very important to pick the procedure and location of the procedure at the facility and the practice which is right for you, which understands your struggles, and which is helpful to you to deliver on the promises. Next slides talk about various levels of body mass index, and this is how we define what obesity is. Body mass index is a formula which calculates and takes into consideration height and weight of the patient. We will focus on 2 categories: category of body mass index of 35 and above, but up to 40, and category of body mass index of 40 and above. Number 1, 35 to 40, is a category where patients are candidates for weight loss surgery if they have additional medical conditions, which we in medical field call comorbidities. As you're watching this seminar today, you may find that you may have any or all of those conditions. For instance, such as type 2 diabetes, hypertension, sleep apnea, anxiety and depression, arthritis, heart conditions, osteoarthritis, and for younger women can be infertility secondary to obesity. So if indeed you have any or all of those conditions, you are here watching the online seminar not because your body mass index is 35 and above, but because you have those medical conditions that your doctors really cannot do anything about it any longer. You've been on multiple medications. You've been prescribed CPAP machine, and you would like to get rid of those medications. You'd like to get rid of the CPAP machine. You'd like to have a healthy pregnancy and live a healthier life. And we're here to help you and to deliver on that promise. At the conclusion of this lecture, I'll show you the slide which shows the percentages of the resolution of those medical conditions. You'll be alarmed to see how high percentage that is. And it's very important to recognize that you are not alone. 65% of adults in America are either overweight or obese, which means that their body mass index is over 30. We have a staggering epidemic of obesity in children, 32%. 5% of Americans are morbidly obese, which means they desperately need surgical intervention. And obesity is a very costly disease, $150 billion spent annually, and it's a very deadly disease. Over 300,000 obesity-related deaths are reported on an annual basis for the past decade. So by doing something about it on a personal level, you definitely can help yourself, help your family, and help the society. And you face obstacles and prejudices every single day, whether going to work, whether on the weekends trying to go to a movie theater, whether you're going on vacation and being forced to buy 2 seats because you can't fit on an airplane seat. You face those obstacles every single day. And it's costing you to be obese. So what are the costs of obesity every single day for you? The next slide shows what I would say personal cost of obesity. It's a very busy slide, but if you read briefly through that, you'll see that if you add all those costs of over-the-counter medications, co-pays for the doctor's visits, co-pays for the specialists, non-surgical diet programs, grocery and dining costs, out-of-pocket healthcare expenses, and last but not least, employment inactivity costs, days of missed work. These costs quickly add up. You may find that dramatic weight loss can greatly reduce your weight-related costs. Diets which are commonly used, such as Zone, Atkins, and Weight Watchers. But what that slide shows, that on average, after 1 year of the program, the weight loss was only 5 to 7 pounds. Now, in comparison to surgical options, which were described in the video you watched earlier today, the weight loss on average will be 50% or 50 pounds of your excess weight. So you compare 5 pounds to 50 pounds, and you know what the difference is, and you know what the right answer is. Surgery is much more durable, gives you more results, and it's quite frankly will cost you less. It's also very important to recognize that if your body mass index goes up, your insurance costs go up. If your body mass index is 35 and above, which means you are a candidate for surgical intervention, the average additional cost of obesity healthcare-related costs is 44%. That means you are paying 44% more than a person whose body mass index is within normal range. So by doing something on a personal level, you can reduce your personal healthcare costs as well. The next video is going to talk about some of my patients' experiences with healthcare cost utilization. And I hope that you'll find it very helpful and useful, and it will resonate with your personal reasons and motivations why you decided to make the next step and watch the online seminar today.
I have relatives that have high blood pressure and diabetes and all these health issues. And being 51 years old, I'm certainly concerned about those issues. I do not have those issues at this time, did not have them before the surgery, and don't want to get them. So I have to make some life-changing decisions.
Everyone in my family is very tall and has been overweight, and my grandmother passed away of pancreatic cancer, and so we knew that that was mostly due to her being overweight, and we realized that was not the road we wanted to go down. And so my mom and I both decided that this was an important decision for us to make, and it's been the best decision that we've made.
What really inspired me to really get my life under control here, a couple of years ago, my mother had a heart attack. And she stayed in the hospital in ICU and in a room for 73 days. And my family and I, we watched her die on a ventilator. She had, all the comorbidities, hypertension, high blood pressure, significant weight gain, diabetes. She had all that. And I looked at her and I thought, look what my family's going through. And then I looked at my son, I thought, I cannot do that to him. I cannot do that to my son when he's my age.
Before we go into the surgical options, we'd like to talk about non-surgical weight loss procedure, which had been approved by FDA since 2015 and available through advanced laparoscopic surgeons. It's called Reshape Dual Balloon. It's endoscopically placed dual balloons, which stay in your stomach for 6 months. Program continues for 365 days, and it's proven weight loss, which is twice as much as non-surgical options such as diet and exercise and medications. Patients who have a body mass index between 30 and 40 are candidates for dual balloon procedure. You are not a candidate if you had previous weight loss surgery. You have to be willing to participate and make lifestyle changes to healthier yourself. Again, procedure takes 15 to 20 minutes to perform. It controls the portions. You have 1 year included of the comprehensive coaching program, and the results are typically twice as much weight loss as diet and exercise alone. And you will see the video animation of the procedure next.
Reshape's unique dual balloons are inserted by a highly trained physician in an outpatient medical setting. The procedure lasts about 20 minutes. During the procedure, the patient is comfortably sedated under light anesthesia. An endoscope is used to insert the balloons through the mouth, down the throat, and into the stomach. Sterilized salt water, called saline, is used to inflate the balloons. Once the balloons are inflated, the endoscope is removed and the insertion procedure is complete. The balloons remain in the stomach for 6 months. After 6 months, the balloons are deflated and removed during a similar endoscopic procedure. Both the insertion and removal procedures are non-surgical, require no incisions or permanent changes to the digestive system, and may be completed in an outpatient environment. For more details about the Reshape procedure, talk to one of the exceptional physicians near you that offers Reshape. A complete list is available on the Reshape Get Started page.
Now, to discuss surgical options is my associate, Dr. Aram Jawed.
Thank you, Dr. Apkin. My name is Dr. Aram Jawed. I'm a board-certified general and bariatric surgeon at St. Clare's Dover Hospital and a member of Advanced Laparoscopic Surgeons of Morris, and I will be discussing your surgical options for weight loss surgery. First and foremost, are you a candidate for weight loss surgery? Well, if you have a BMI of greater than 35 with comorbidities such as obstructive sleep apnea or diabetes, for example, or if you have a BMI of 40 without any comorbidities, then you are a candidate for weight loss surgery. You also have to be healthy enough to undergo a major operation, have failed attempts at medical weight loss, absence of any drug and alcohol problems, along with no uncontrolled psychological conditions, and you have to understand the surgery and the risks. Most importantly, you must be dedicated to a lifestyle change and lifetime follow-ups after surgery. The 3 most common bariatric surgical techniques in the United States today are, number 1, the vertical sleeve gastrectomy in the middle of the slide, which is a purely restrictive procedure. Number 2, the Roux-en-Y gastric bypass, which is malabsorptive and restrictive on the right side of the screen. And number 3, the adjustable gastric banding, which is purely restrictive procedure on the left side of the screen. We want patients to know what to expect for each procedure after surgery. As you can see here, the gastric bypass surgery and the laparoscopic vertical sleeve gastrectomy are similar in excess weight loss. With the bypass, you have 80% of your excess weight loss after 5 years. With the sleeve gastrectomy, it's 60 to 70% of your excess weight loss at 5 years, whereas the laparoscopic adjustable gastric banding, you have 40% of your excess weight loss at 5 years. Now we will discuss the most common procedure conducted in the United States today, which is a vertical sleeve gastrectomy, purely restrictive procedure, which takes about 75% or more of the stomach out, with a mean excess weight loss of 55 to 70%, no implantable medical device, and importantly, depresses the hunger hormone ghrelin. This is a video that depicts the steps of the procedure for a vertical sleeve gastrectomy.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food, and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
What are some of the risks and complications of a vertical sleeve gastrectomy? Well, dehydration and nausea are number one, but usually dissipate 24 to 48 hours after the procedure. Staple line leaks, which is 0.5% and very rare because we test the staple line intraoperatively. And also you have rare complications such as stoma obstruction, stretching of the stomach, additional need for surgery, and vitamin deficiency. Next, we're going to talk about the second most common procedure that's conducted in the United States for weight loss surgery, gastric bypass, where a small stomach is fashioned and the intestines are rerouted for both restriction and malabsorption, where patients will get a mean excess weight loss of 64% at 10 years. Again, there's no implantable medical device, and this procedure also importantly depresses the hunger hormone ghrelin. Here's a video depicting the steps of the procedure of a gastric bypass.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
So some of the complications of a gastric bypass, again, are leaks from the staple line, which are very rare because we test them intraoperatively. You can also have marginal ulceration and possible internal hernia, which is both minimal at 5%. With the gastric bypass, you can have a dumping syndrome, which is nausea, vomiting, and diarrhea from self-induced overconsumption of carbohydrates. And with any weight loss procedure, you can have vitamin deficiencies. The third most commonly performed bariatric procedure is the adjustable gastric band, where a band is placed over the stomach and a subcutaneous port is placed under the skin in order to inflate the band. With this, you have an excess weight loss of 25 to 40% at 5 years, and ghrelin, the hunger hormone, is actually increased. This requires an implanted medical device and ongoing maintenance, such as band adjustments after surgery. This is a video depicting the steps of the procedure of a laparoscopic gastric band.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The realize band is introduced to the abdomen through a trocar. The realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced into the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch decreases the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
The complications of a gastric band are that you can have an esophageal dilation above the band can actually slip out of place, which is called band slippage, and the band can also erode into the stomach itself. Now, if after a gastric band, if you are losing 1 to 2 pounds per week, you may not actually need a band adjustment for some time. Band adjustments usually start 6 to 12 weeks after the operation. They are done either in the office or under fluoroscopy, and it usually takes about 2 to 4 adjustments in the first year to obtain optimal band restriction. This is all usually covered by your insurance. So what can you expect after weight loss surgery? Recovery takes time and patience. You may experience discomfort and pain as your body heals and the capacity of your stomach is much reduced. Length of time to return to normal activities can vary from patient to patient, but usually it's about 1 to 3 weeks. We will advise you when to return to work, resume prior activities, and schedule your follow-up appointments. Most patients see weight loss of about 10% of their weight in the first month. So now Dr. Apkin is going to wrap up the online seminar.
Thank you, Dr. Jawed. Now, for the summary of our presentation, we're going to talk about improvement in medical conditions. If you have type 2 diabetes, it will go away or improve between 82 to 96% of the time. If you have high blood pressure, it will go away or improve between 62 to 70% of the time. If you have obstructive sleep apnea, it will go away or improve between 74 to 98% of the time. For women of childbearing age, if you have polycystic ovarian syndrome or infertility, it will go away or improve between 75 and 100% of the time. If you have headaches, migraine headaches, secondary to obesity, it will improve or go away in 57% of the time. If you have arthritis, osteoarthritis, it will go away in 41% of the time. Last but not least, your quality of life will improve in 95% of the patients. And no medical doctor can give it back to you the same way as weight loss surgery can. So we're very happy, and hopefully you'll find that our program is the right place for you. How do we choose the procedure that's right for you? We take into consideration your age, your health risk, the amount of weight you want to lose, your lifestyle, and your eating behaviors. And this is a mutual decision, which we discussed at the time of the consultation, and will help your family and friends to make a decision as well. So if you like so far what you heard, you probably are wondering, what are your next steps? And this is what I would suggest we do. We start with the Bariatric Success Program pre-surgery and continue after surgery. So really, we don't start with surgery. We start way ahead of the time. And the pre-surgery part is very important, and it's actually mandated by a majority of the insurance companies. So pre-surgery part consists, obviously, from the surgical consult, where you get to know your surgeon. Is this surgery right for you? Is this the best surgical option? Is the best right time for you? Any questions you may have will be answered at the time. We'll start with nutritional evaluation or multiple nutritional evaluations if that's what the insurance company requires. This is a primary education on bariatric diet. We'll answer any of your questions about diet, We check your level of understanding and commitment, and we'll develop a follow-up nutrition and counseling plan customized for you. And we'll also put you through a psychological evaluation, because you may have some issues that would make surgery a bad choice for you or a bad time for you. We'll find out if support system you have is good, and do you need any follow-up counseling. All that starts way before surgery and continues after if necessary. We also offer free monthly support groups, both in person and online, and we want to make sure that the program is fun, because we want to make sure that you achieve high quality of life and live healthy, happy life as long as possible. The next slide is commonly asked questions. What I mean by that is when patients come for live seminar or come for personal consultations, these are typically few questions, if not all questions we get. So we'll go through them one by one. Number one, pregnancy. 70 to 80% of our patients are female, so a lot of times they want to make sure that they can get pregnant after surgery and the pregnancy will be healthy. And the answer to that is, of course, you can, and yes, the pregnancy will be much healthier and the baby will be healthier. Because when you lose the weight, your medical problems which lead to unhealthy pregnancy or high-risk pregnancies such as diabetes, preeclampsia, or high blood pressure goes away. So all we ask you to do is try not to get pregnant for the first year, which is most rapid weight loss time, and then by all means go ahead and continue with the plans for your pregnancy. Which leads also to the questions of vitamins. How long and what vitamins do I need to take? We all know that vitamins are necessary to take without surgery, so we will find out how many vitamins you need to take and for how long by doing your blood work after surgery. We'll be doing the blood work every 3 months for the first year, and then once a year thereafter for as long as you're willing to come, and we'll adjust the levels of the vitamins required to take accordingly. Sometimes band patients or patients who are contemplating the band want to ask the question, how long can the band stay? Material which is band made of is durable to stay in the body for 30 to 40 years. Or as I would put it, it will go with you wherever place you're going. It can permanently stay in your body. But as Dr. Jawed earlier mentioned, most likely something may happen before the expected lifespan of the band, which will prompt removal of the gastric band and possible placement either of the new band or conversion to another procedure. So therefore, the issue of longevity is not a factor. Let's say we have a patient who had a gastric band and it worked for the person for a while, but then something happened to it, as Dr. Jawed mentioned. So what do we do with that patient? And yes, the gastric band can be removed laparoscopically, and yes, it can be converted to either gastric bypass laparoscopically or sleeve gastrectomy laparoscopically. So that is not a problem for us. Of course, some practices may find it's more complicated to do, but we have excellent track record of revisional bariatric laparoscopic surgery. Sometimes patients have other surgeries before they consider weight loss surgery. So they are concerned about the fact that, well, I already had surgery, including open surgery, such as gallbladder or hernia or appendix. Am I a candidate for laparoscopic or minimal invasive approach? And the answer to that is, of course you are. What that means that you have some scar tissue or what we call adhesions in the abdomen, and we will have to spend some time freeing that scar tissue or lysing those adhesions before we can proceed with a weight loss surgery of your choice. But that does not make you not a candidate for laparoscopic approach. Another question which sometimes comes up is gastric bypass is a big operation. Can it be reversed? If it's medically necessary, indeed it can be reversed, and if it was done laparoscopically, indeed it can be reversed laparoscopically. The next question is sleeve gastrectomy reversible? We remove a portion of the stomach, therefore sleeve gastrectomy is not a reversible procedure. Last but not least, would insurance cover my surgery? So when you decide to make an appointment for a consultation, we will ask your permission to review your personal health insurance coverage. So by the time you come for a consultation, our specialist will sit down with you and go over your coverage. And most of the time we find that insurance companies are willing and able to cover weight loss surgery coverage. So that is all will be taken care of when they make an appointment for personal consultation with a surgeon of your choice in the office. Well, if you liked what you heard today, I do hope that you come to Dover Hospital, where we have state-of-the-art equipment in the operating room. And once you come to the patient's room, they have private rooms which will make it very comfortable for both yourself and the family for your stay. I hope to see you very soon.